Hi, this is Dr. Bob Dannenhoffer. I'm the Public Health Officer for Douglas County, and we're here today with another of our COVID conversations now for the week of December 16th. I'm joined today by Sarah Zia, who's our modernization epidemiologist, and we'll get to her in a little bit. But as we always do, we use this time to go over the world situation, the situation in the United States, and then the local situation with COVID, and then answer a bunch of questions that people have had about COVID. So we'll get to those today. If you do have questions, the best way to do it is to submit them to us at Facebook questions at douglaspublichealthnetwork.org. I know it's long, but Facebook questions at douglaspublichealthnetwork.org. And we'll get to those questions. We have a few excellent questions today that we'll get to. So, as always, we start at the world level and move our way down. And in the world, the number of cases is up, the number of hospitalizations are up, and the number of deaths is now starting to rise again. Most of the disease we're seeing is in the northern parts of the northern hemisphere, especially in the US, Central Europe, and in Russia. We're starting to see quite a bit of disease in places in Northern Europe that have not had a lot of disease before. So, for example, Norway, Sweden, and Finland have been relatively quiet until just the last few weeks, and now they're seeing very high levels of disease. We're also very worried because we're seeing a real increase in cases in the United Kingdom. And if you remember, if you've been watching these, that the United Kingdom has been the best canary in the coal mine. Every time they have a surge due to something new, be it Alpha, Delta, about 6 weeks later, the US has the same surge. And they're just now starting with a big Omicron surge, which would suggest that within the next 6 weeks, that is somewhere in the end of December or January, we too may start to see that surge in the United States. We're also seeing a real increase in disease in Southern Africa. It started out in South Africa, in one little place in South Africa. Now it's spread through much of South Africa and is now spreading to neighboring countries. What we know is that disease in a continent like Africa or Europe starts in one place and then spreads to other bordering countries. So we're very worried about what could happen in Africa. In the US, cases, hospitalizations, and deaths are really sharply up. And they're mostly sharply up in the area of the Midwest and New England, pretty much all the cold places. There's really a line in the US where the warmer places have not yet seen this big surge. And some of those places are really struggling. I have friends in Michigan and in Pennsylvania that tell me that their hospitals are really, really clogged up with patients. And even Massachusetts, which has a lot of hospital beds, is struggling to meet the demand. So the disease is there. In the US, the disease is almost all Delta. So while we've detected Omicron in those other areas, almost all of these cases, hospitalizations, and deaths are still due to good old Delta. It was never good, and unfortunately, it's not old enough. But anyway, in the country, the rate is about 37 cases per 100,000 per day. It's about twice what it was 4 weeks ago. In Oregon, we're at also 17 cases per 100,000 per day, as we've been for the last several weeks. And cases in Oregon are stable and reasonably quiet. In Douglas County, we're a little higher than Oregon, but lower than the country as a whole at 28 cases per 100,000. And we continue to see outbreaks in workplaces, long-term care facilities, jail, houses, parties, and especially on school sports. We don't see very much spread in school itself, but school sports, because kids tend to be together for a very long period of time, they may not be wearing masks in the locker room or when they're playing, and because they can frequently have close activity, we are starting to see some spread there. The disease is overwhelmingly among the unvaccinated. So in Douglas County, about 50% of the whole population is vaccinated, about 50% is not. And almost all the cases we see are in the unvaccinated. When we get to hospitalizations, again, overwhelmingly 5 or 6 times more likely to be hospitalized if you're unvaccinated, and more likely to die. So we did a recent study where we looked at the deaths of people 65 and older over the last 6 weeks. And in though we had 24 deaths, and 15 of those deaths were among the 7,000 seniors who were unvaccinated. So 15 deaths among the 7,000. There were 9 deaths among the 24,000 who were vaccinated, and there were no deaths among the 7 or 8,000 who were boosted. So what this shows is that not being vaccinated is a terrible risk factor, and that boosters really work to decrease hospitalizations and deaths. I went over the hospitalizations today, and of all the hospitalizations we've had in the last 2 weeks, we've only had a single person who'd been boosted. So that really does seem to be the best protection. Previous infection is pretty good, but really boosted vaccination seems to be among the best protection you can have. Vaccines are still widely available. We are recognizing that we have a bit of a logjam with pharmacies, with pharmacies closing and other staffing issues in pharmacies. But we've had 2 big events last weekend. We're going to have another big event on December the 29th, a drive-through event at the Fowler Street parking lot across from the library, where we're going to be able to do booster vaccines. Just show up and get them. The other thing that we're looking at is we're working with a group of local people to see how well Regeneron works. And it appears that Regeneron is working just as promised. So you remember the data suggests that it's going to be 70 to 90% effective in preventing hospitalizations and death. And our data has shown just that, that people who got Regeneron are much less likely to be hospitalized and much less likely to die than people who did not get Regeneron. So we really are suggesting that if you are diagnosed with COVID and are in one of the high-risk groups, especially if you're over 65 or if you're over 50 with an underlying condition, you talk to your doctor about the possibility of getting Regeneron, because it really could decrease your risk of getting hospitalized and decrease your risk of dying. So all focus this week has been about Omicron, and I'd love to tell you that I know exactly for sure what's going on with Omicron, but it's hard to tell. This is what we do know, is that the Omicron variant is really quite different from the previous ones. They do these trees that show how these things develop, and many of the variants started with one mutation, then collected others until they got to be one of the other variants. This one just started from nothing and now has about 50 different mutations on the virus, which makes it so very different from the others. We think this probably developed either in animals and then brought back to humans, or developed in an immunosuppressed human who made all of these variations and then it got out. We don't know for sure, but it does seem to be more contagious. So when we look at the spread in South Africa, when we look at the spread in other countries, it does seem to spread very quickly and may be as contagious or even more contagious than Delta. That's hard to believe because Delta is already really quite contagious, but this one appears to be very contagious. So, for example, at a university in the East, they had 27 cases. A week later, they had 276 cases, suggesting that this was doubling every couple of days. That's a very fast doubling and really a suggestion that this is quite contagious. The second question is, how well are vaccines or Regeneron going to work against this one? The data out today suggests that Regeneron may not work as well, but we don't know how much less well. The data on the Pfizer and the Moderna vaccine is that 2 doses will help a little bit, but 3 doses, that is getting your initial series and then a booster, will give a lot of protection. So again, we're totally recommending that everybody who's eligible for a booster get a booster just as soon as they can. And again, you can get them at doctor's offices. You can get those at Aviva. If you call them at 541-672-9596, or we're going to have our event on December 29th. That's in between Christmas and New Year's. We're going to have a drive-through that Fulton Street lot, and we're hoping to get as many people boosted as we can. The other question is about the antiviral drugs. There are 2 antiviral drugs that are on the table. One is a drug called molnupiravir. That drug is not that effective, considerably less effective than Regeneron. And so that's kind of stagnated. But there's another one made by Pfizer, which looks to have 80 or 90% protection against hospitalization. That's even better than Regeneron. And because it's easier to use and will likely work for any other variants, that seems to be the hot one right now. So we're carefully looking to see how we can get that drug out to people to help decrease the effects of this. So let's talk with Sarah now. So Sarah came to us working at DPHN in the last few months. And before that, Sarah, you worked on PCR. So tell me a little bit about what kind of work you did with PCR, and explain that maybe to people. That's a tough one to explain.
Yeah, so once the nasal pharyngeal swab is collected, it's put into a test tube with a lysis buffer, and this buffer inactivates the virus. And then once we have the sample in the lab, we pipette the lysis buffer and put it into a 96 well plate with MS2. And the last two wells are for the negative and positive controls. The MS2 is added to these well plates to as a way to control the amplification process and prevent false negative results due to inhibition or just human error. And once the 96 well plate is prepped with all the samples, it's ready to put into a machine to isolate the RNA. Once the RNA is extracted, a master mix is added to it. This mix is consisted of reverse transcriptase, nucleotides, primers, TACMan probe, and DNA polymerase. And the solution is put into a PCR machine, which is basically a thermocycler that targets sequences to amplify, such as the spike protein, viral envelope, the membrane, and nucleocapsid protein. And this is done through heating and cooling of the solution, which results in the denaturation, annealing, and extension of the targeted sections. For denaturation, you would be heating it, the sample, and then it will be cooling during the annealing and extension process. By doing this over and over, you are making copies of the target section. And once that happens, you can analyze the results and determine if you're COVID positive if the S gene is above the threshold, so the spike protein. And that's a short synopsis of how PCR testing happens and how you get your COVID results.
Well, thanks for that answer about PCR. I've done a bunch of these swabs, and what we know is that it's uncomfortable to get the swab done, and that during this time we've had shortages, sometimes of the swabs, sometimes of the pipettes, sometimes of the reagents. But this is really very complicated. You know, my explanation for 5-year-olds is that we make copies of this like you would make many copies on the photocopier, and when it gets to be enough copies, you can actually see what you're looking for. But obviously, it's much more complicated than that. So thank you. So when you work doing this, did you? It takes a long time to learn how to do this. So tell me about the training you needed to do to run one of these very expensive machines.
Well, first off, I was pipetting for a few weeks because that's a very important skill once you're working with basically a droplet of liquid. So there wasn't really any room to have an error since you didn't have any more sample to really work with. And then you get to move on to the machines. You can start with centrifuging samples and reagents, and then go towards heating by pressing a button that starts a preset temperatures and number of cycles. And then you get to the reading the results, and that you have to train for quite a while to be able to send off results and read the results.
Well, that's great background for the COVID work. Now at DPHN, you're helping us out in the COVID work, but you're also working on some of the modernization stuff, especially about health equity. And I understand you're going to be part of the Health Equity Coalition in here. So tell us a little bit more about that health equity work.
Yes, so currently I'm looking at data to see infection rates among between different communicable diseases and seeing how they vary between the different races and ethnicities, and determining if the risk of infection varies between these races, depending on the year or age or just any variables.
Well, we certainly have seen inequities in the past. So, for example, syphilis seems to be much more common among certain groups than others. And we've also seen with COVID that there are great inequities. So, for example, people in the Pacific Islander community, many times because they work in crowded factories, really suffered a great blow from COVID early on. We also know that our seasonal workers, many of whom were Hispanic, also suffered disproportionately from COVID. So you're working on that. So epidemiologists, my brief understanding for 5-year-olds is that epidemiologists look at data and make sense of lots of data. How do you see the job as an epidemiologist?
That's definitely how I see it too. It's a lot of data-driven decision making and seeing how disease in our community is spreading and trying to pinpoint how we can mitigate that.
Well, that's going to be great. So that's some of the work we're looking to do as COVID, we hope, slows down, and we'll work more on health equity and other modernization work. So, how have you found Roseburg? I know you've been here for just a few months. How's it been for you?
It's been great. It's so beautiful. I'm glad I get to see the South Umpqua every day on my way to work, and I just love it up here.
Well, good. Well, we're certainly incredibly glad to have you here. So thank you, Sarah, for joining us. And that'll end our COVID conversation for today. So if people have questions, please submit them to us at COVID questions at Douglas Public, Facebook questions at douglaspublichealthnetwork.org. Again, Facebook questions at douglaspublichealthnetwork.org, and we'll get to them next week. We will do this again next week. I know it's Christmas week, but we want to keep people informed. And I think by then we'll know a little bit more about the Omicron variant and its effect in the next few weeks. So again, thank you so much. And again, thank you, Sarah, for joining us.
Thank you for having me.